organization. And he called me at about 4 o'clock after he'd been elected, and he asked me to come and work with him. So I said to him that I will come work with you, but the one thing that I really insist upon is that we've got to do something in the spirit of what President Bush had done, what President Bush had done for 15 countries. The PEPFAR program was really 15 countries. We have to do something bigger for the whole world. So we started this crazy campaign, 3x5. This was one of the most controversial campaigns that WHO ever got involved with. So we took over WHO in the summer of 2003. So there was only 2.5 years before the end of 2005 to go from about 300,000 people on treatment all the way to 3 million. Everyone told us it was impossible, it was crazy. But already by that time, I'd been working with folks who are specialists in quality improvement, in business and management. And what they told us was, unless you have a concrete target, people won't do anything, especially in developing countries. And I think it was true. So what happened? Well, in mid-2003 when we started, there were about 350,000 people on treatment. And those 350,000 people on treatment were mostly in Brazil. There was this rise in the number of people on treatment, and people who've been in global health for a long time have said they've never seen anything like this. The ministers of health of most of the developing countries were furious at me, and they would come and say, how can you expect us to do these crazy things in such a short period of time? But it was that target, it was setting the target, it was moving people along. We set up new guidelines, we simplified treatment protocols, we made generic drugs available at around, the price was started at $300 around 2003, but it went down to $150 per person per year thanks to the Clinton Foundation. So we made things happen, and now it looks like we're going to reach our target of 3 million on treatment by the middle of 2008. So we would have missed the target by about 2.5 years. And I became very interested in the history of WHO, and it's pretty clear that missing a target about 2.5 years is just about the best WHO has ever done in reaching a target. So right around the summer of 2005, there was a meeting, and these folks, when we came in January of 2003, President Bush was the only leader who said that it was important to treat people with HIV. By the summer of 2005, just about 2.5 years later, all of the leaders declared that we should have universal access to HIV treatment. This was amazing. And so I was still living in Geneva in the summer of 2005, and as soon as I saw this meeting happen, as soon as I learned that they had committed to universal access, I prepared to come back to the United States. We were not crazy about living in Geneva. The biggest reason was that they had really, really bad and really, really expensive Chinese and Korean food there. My new theory, my new anthropological theory is that if you go to a country and they don't have good Chinese restaurants, that economy is probably in trouble. Right? All over Africa, lots of great Chinese food. I'm Korean, but and there's not very many Korean restaurants in Africa, but there are some great Chinese restaurants. All right, so what's the point of setting such a bold target for something like HIV treatment? For me, the point is not treating people with antiretroviral drugs. The point is that clinics look like this all over the developing world. And what you really want to do is take the money, which is a lot for HIV treatment, and take advantage of the fact that for the first time in history, the richest countries in the world, the most powerful men in the world, have committed to providing chronic care for a chronic condition for the rest of the life of a poor person. We've never done that before. Right? HIV treatment means you're going to treat them until they die. And we have never, ever committed to chronic care for a chronic condition before in such a big way. So we've always, when many of us, Paul Farmer and I conclude, when we really pushed for HIV treatment, when I pushed for the 3x5 campaign, it wasn't because of antiretrovirals. It was because we wanted to get the most powerful countries in the world to commit to chronic care. When you commit to chronic care, what's possible is primary care. So here's what we do. In Haiti, we used HIV money to build a primary care system. If you have the drugs available, if you have trained people, people will come. In Rinquavu, this is Rinquavu in Rwanda, we were given this health center. This is a post-genocidal state. Many of you know the awful history of Rwanda. During the genocide, many, many people were killed in these health facilities. This is what the actual health center looked like. So we spruced it up. We began offering primary care. What we do is, instead of just treating HIV, we also treat TB. We provide services for women's health. We also treat sexually transmitted diseases, and we care for children. And if you put all those things together, it's really basically a pretty well-functioning primary care system. So we actually had someone from the Clinton Foundation, our partners at the Clinton Foundation, send us a business person to do a business study. And it turns out that it costs us to provide comprehensive primary care about $25 per person per year. Compare that to the US, in which we spend about $6,000. Well, it's closer to $7,000 now per person per year. Now, you know, we're doing better. There are lots of people on treatment. We're really building primary care systems. But take the country of Lesotho, and I was just here. So Lesotho is a small country, and it's completely surrounded by South Africa. So in Lesotho, they have one of the worst epidemics I've ever seen. Now, this is a complicated graph, and what it really is from the Centers for Disease Control of the United States. They documented the worst outbreak of XDR-TB, extensively drug-resistant TB, that we've ever seen. Now, in Lesotho, 30% of the adults are living with HIV. So every third adult has HIV, and now there's this epidemic of extensively drug-resistant TB that's hitting this country, and it's coming from South Africa mostly. What do you do? Well, in this particular case, these XDR-TB cases, there were 53 of them. 52 of them died. And the average length of time from the diagnosis of their tuberculosis to death was 16 days. So this is an epidemic that's just ripping through this particular area. And it's everywhere. It's in the mines. We had a group, when I was there in Lesotho, we had a group coming from the place that actually was the host of this epidemic, Tugela Ferry. He told me that they have 300 drug-resistant TB patients currently on the wards, and the vast majority of those patients have XDR-TB. What do you do? It's the most complicated treatment that you can ever imagine, and these people are also living with HIV. What the heck do you do when these people are infecting the Android teachers of the world who get on planes and come back to Atlanta? You have no choice but to actually treat them. There's no way to prevent XDR-TB from infecting someone else other than by treating the ones who are sick with it. So we've got this challenge. This is the challenge we have. It's the most complicated challenge I've ever seen, and we're in the midst of trying to deal with it right now. The basic point, though, is that it's not just XDR-TB that we're not doing well with. We're not doing well with vaccines, with primary care, with drug therapies, maternity. We're not doing well with any of these things. And I refer to it as an implementation bottleneck. The numbers are terrible. Preventing mother-to-child transmission of HIV. In the United States, we can prevent almost every single case of transmission. In other words, if a pregnant woman has HIV, we can prevent almost every single case. Maybe you know, if we have 1%, that 1% is because we've made some grave errors. We can prevent almost every single case. A woman with HIV who's pregnant should not transmit it to her child. But in Africa, it's 25 to sometimes 50% of the cases are transmitting HIV to their children, either during birth or afterwards through infected breast milk. And the interventions are not simple, but we should be able to get them to everyone. We should be able to prevent mother-to-child transmission, but about 10% of the women who need it in developing countries get it. Huge amounts of investment. You know, here's Bill Gates. He's putting all his money into global health. Warren Buffett just pledged another $37 billion, so it's $80 billion. The Gateses are doing wonderful things. They're really focused on new tools. Now, you know, drug-resistant TB, what do we need? We need new drugs. And so the Gates Foundation is really focusing on making new drugs. But what's going to happen if we get all these new drugs and we're still implementing and delivering at the rate that we were before? It's just, the implementation bottleneck is just going to get tighter. There's no law of hydraulics that I know that says if you put a new tool on top of a bunch of old tools that aren't being delivered, that somehow it'll flush them through the system. It just won't happen. These new tools will simply make inequality worse. It'll be you folks and travelers, other travelers from the first world who get access to these drugs. The poor won't get access to them. So what do you do? Well, I've talked to a lot of people, and I've talked to just about everyone at Harvard Medical School and Harvard School of Public Health about